Dear colleagues, I'm Christoph Diener from the medical faculty at the University of Duisburg-Essen in Germany. And I have today six publications from March 2024. Main topics are headache and epilepsy and antiepileptic drugs during pregnancy. Let me start with headache in children and adolescents. There is a very important study from Canada with almost 5 million children, adolescents aged 5 to 17. And they looked whether these children either had infrequent headache, which is 1 or less days per month, or more headaches than 1 per month. And 300,000 of these children and adolescents had frequent headaches. And lifestyle factors which were associated with an increased number of migraine days or headache days were, not surprising, increasing age and female sex. But headache was also associated with irregular meals, the so-called late chronotype, which are children who go to bed late and cannot get out of bed in the morning, and more than 21 hours of screen time per week. There was no significant association with physical activity. And in the age group between 12 and 17, predictors of frequent headaches were alcohol use, smoking, and cannabis use. And some of these factors have clear implications for consulting children and adolescents and their parents. And most probably the factors that can be influenced most easily is screen time. The next study, the PRAISE study, published in JAMA Neurology, compared in Spain a monoclonal antibody against the CGRP receptor erenumab with standard oral prophylactic therapy. This study included 621 patients. 2/3 received erenumab 70 or 140 milligrams once monthly, and the other ones received all preventive therapy, and they were followed for 1 year. The primary endpoint of the study was the adherence to therapy after 1 year and an at least 50% reduction in monthly migraine days. This endpoint was achieved in 56% on erenumab, and with oral migraine prophylaxis in 17%. The 50% responder rate was 76% versus 19%, and the discontinuation rate to side effects was 3% with erenumab and 23% with oral migraine preventive therapy. And this is a very strong argument for the use of monoclonal antibodies, in this case in frequent episodic migraine. The only downside is the still high costs of monoclonal antibodies. My next study, published in JAMA Network Open, deals with bleeding risks in people who are anticoagulated and have atrial fibrillation. We know that selective serotonin reuptake inhibitors, SSRIs, used for the treatment of depression have slightly increased risk of bleeding. And the reason is that these drugs inhibit platelet function. Now, this was a population-based case control study from the UK, which looked at the consequences of concomitant use of selective serotonin reuptake inhibitors and oral anticoagulants. They identified 42,190 patients with atrial fibrillation who had a major bleed, and they had 1.1 million controls atrial fibrillation anticoagulated without SSRIs. The incidence rates for bleeding were increased by 40 to 60% with concomitant use of SSRIs. This was true for any kind of bleeding, GI bleeding, and intracranial bleeding. The risk was the same for DOACs and for vitamin K antagonists. And in clinical practice, this means that people who have a high risk of bleeding and atrial fibrillation and depression most probably should receive a tricyclic antidepressant. And my last 3 studies deal with the possible consequences of exposure to antiepileptic drugs during pregnancy. The first study, published in the New England Journal of Medicine, looked at the autism risk at age 8 years after prenatal exposure in women with epilepsy to topiramate, valproic acid, and lamotrigine. And what they found was, in the 4.2 million children whose mothers were not exposed to antiepileptic drugs and had no epilepsy, the risk of autism was 1.9%. And the incidence in mothers with epilepsy without antiepileptic drugs was increased to 4.2%. But with exposures to valproic acid, the risk was increased to 10.5%, with topiramate to 6.2%, and lamotrigine 4.1%. And when corrected for confounders, the increased risk was only observed for valproic acid. The next study is a cohort study on the risk of serious malformations, congenital malformations, after exposure to antiepileptic monotherapy, published in JAMA Neurology. This was an observational study in children up to the age of 1 year. A total of more than 10,000 pregnancies were evaluated for the 8 most commonly used antiepileptic drugs, and the malformation rate was increased for valproic acid with 9.9%, phenytoin 6.3%, phenobarbital 6.2%, carbamazepine 5.4%, topiramate 4.9%, and lamotrigine 3.1%, oxcarbazepine 2.9%, and levetiracetam 2.5%. The increased risk of serious congenital malformations was significantly increased for valproic acid, phenobarbital, and carbamazepine. The good news is that between 1998 and now 2022, the number of children in females with epilepsy decreased from 6.1% to 3.7%. The last study deals with the prenatal exposure to antiepileptic drugs and postnatal neurological and psychiatric disorders. This is a meta-analysis of 43 studies. They observed an increased risk of autism and intellectual impairment with valproic acid, and an increased risk of autism for topiramate. There was no increased risk for lamotrigine, and we have insufficient data for the new antiepileptic drugs. I think these studies have clear implications for the treatment of women with epilepsy who want to become pregnant. The major problem with valproic acid and topiramate is not only the treatment of epilepsy, but also migraine prevention in females with these 2 drugs. Dear colleagues, I'm Christoph Diener from the medical faculty at the University of Duisburg-Essen. Thank you very much for listening and watching.